Is there anybody want to ask question? Okay. Okay, please. Dr. Riri from Solo. Please.
Thank you for the opportunity. My name is Riri. I would like to ask the Dr. I have two questions. The first one is there any approach you would like to suggest us, whether to see or to screen for the malignant form of endometriosis from the ultrasound? What would you like to suggest to us?
Okay,
the
gotcha.
malignant form. That was the first question. The second is about the salivary sonogram. It's quite new. I would like to read about that and how many cells we have to insert to the uterus. How many? How much?
I think she asked about the techniques of saline diffusion sonography.
Sure. So second question first. When we were doing sonography intraoperatively, we were using between 30 and 60 mils of saline. But I think if you scan your patients in the second half of the menstrual cycle, a lot of them will have some fluid in their pelvis anyway, so you won't need to subject them to that particular test. And also you need to make sure that their fallopian tubes are patent. And so from that perspective, if someone hasn't got patent fallopian tubes, then you can't do sonography. And to your first question, there's no doubt, and there's a greater amount of published literature with the connection between endometriosis-associated ovarian cancers, particularly clear cell carcinoma and endometrial adenocarcinoma of the ovaries, and particularly those women that are transitioning through the menopause. I don't think there's any. The IOTA group haven't defined the ideal time for following these women up and how often they should be scanned. So I think it would need to be an individual choice, but probably, I mean, I remember we were running the ovarian screening for those with BRCA1 and BRCA2 when I was doing my job in London. This was many years ago. And we were also following up women postmenopausally who had endometriomas in the postmenopausal phase, and we were following them every year. And one of our patients in that 12-month interval developed endometrial adenocarcinoma. So perhaps the interval needs to be shorter.
I think very sound, clear, and detailed, Dr. Riri. Okay. Thank you, Prof. Just on those. And we move into the next question, please. Dr. Aris Hartoto. Want to make question or sing? Okay.
Thank you very much. To Dr. George. Probably there is something I missed about what you present. I still don't understand how to differ between fluid appearance in the pouch of Douglas between normal fluid, PID, and to the endometriosis. You present some fluid in pouch of Douglas. I still don't understand how to differ between endometriosis, PID, or normal fluid. Thank you.
I think this is very practical, but
it's something that I highlighted myself. I think that we've got ahead of ourselves. So there's been, I think, now 3 studies where different units around the world have been able to visualize and confirm the presence of superficial endometriosis. I think the challenge is to try to understand what other conditions are also associated with similar ultrasonographic features that we see in patients with superficial endometriosis. So I don't know the answer to your question, but I think that the ideal study would be to have a group of women who have confirmed chlamydia or gonorrhea. They come through a sexual health clinic. We then perform an ultrasound scan on those individuals and then see before and after they present whether they have similar features to what we've described when it comes to superficial endometriosis. There will be an addendum coming out by the IDEA group that's just been accepted in the White Journal, and so we talk about in detail about the different morphological appearances and the types of fluid that you see in relation to those patients with superficial endometriosis. But your point's a good point. I think that that's why I'm not so instructive or prescriptive when I report on these cases. I say that these features may be suggestive of underlying superficial endometriosis.
Okay, I think that's very clear then. And because it's not very ideal, Dr. Prasan Acharya got a question, so I want a question. to you. Yeah. Because it's very interesting what you are giving us an idea, like opening our mind, how we will reshaping our practice. You know, many people say that non-invasive prenatal testing and IPT will kill ultrasound, but you has just shown to us that it will not kill the ultrasound, yeah, because it's not merely only structural anomaly due to chromosomal or genetic anomaly. There is anomaly not related to the genetic and also the chromosomal, and also about to see the placentations, the vascularization, the fetal well-being, and other. But how can we possibly know most of the problems in fetal development from the earlier beginning before 12 weeks of gestational age? Yeah, because we tend to be trying to push and push harder to know everything beyond 12 weeks, beyond 10 weeks and beyond 8 weeks. So if some like prognostication of the later malformation, we notice it very clearly, so we can terminate early for that. For the test.
See, as I told you, I have given you in my slide, I showed you 3 groups. Always detectable, always undetectable, and third, potentially detectable. You cannot diagnose first trimester. There are some malformations which you cannot diagnose. Say for example, there are C-CAM. You cannot have congenital adenomatous malformation diagnosis in the first trimester of the thorax or the lung, which is practically always diagnosed after the second trimester. But there are many defects which previously were never diagnosed in the first trimester, like a posterior fossa malformation, like absent corpus callosum, like there are many cardiac defects, diaphragmatic hernia, short long bones, renal agenesis. There are many defects which were not diagnosed during the first trimester. Now they are all could be diagnosed. And there is a fixed pattern of disease which was initially suspected in the first trimester and then diagnosed in the second trimester. Now because we know that pattern, if we have understood that pattern in our mind, that we will predict that okay, right from the first trimester there are a lot of problems in the first trimester. Fetal echocardiography is one classic example of diagnosing majority of lethal cardiac defect right there in the first trimester. Same thing is with the fetal brain. The lethal CNS malformation, you can diagnose all acranias. Same way you can diagnose all holoprosencephaly should be by before 10 weeks, not 12-13 weeks. I am talking about 10 weeks and 11 weeks. You should be able to diagnose, because holoprosencephaly, you know that you cannot, the way that life is not going to be normal. They are not going to survive. All major cleft lip and palate, involving bilateral cleft, bilateral palate, you should be able to diagnose right there in the first trimester of the pregnancy. There are many posterior Walker-Warburg syndrome that you will be able to diagnose right there in the first trimester of the pregnancy. Gross vermian agenesis, you will be able to diagnose. Joubert syndrome, you will be able to diagnose right in the first trimester. So there are many things which will be diagnosed not by second trimester, but by the end of the first trimester, by 13 week, 14 week, you should be able to diagnose, and that's what shift will happen. Initially it was after the birth which was diagnosed, then we started during the third trimester. Now then the second trimester, now we are shifting to the first trimester and late first trimester. Now it will go to the early first trimester. So that shift will always happen.
Thank you very much, Dr. Prasanna Acharya. So for wrapping up this session, I think the bottom line is the upcoming forward, the future is not merely only about a better machine and better technology, but how the operator could have a better competency to make a better clinical practice. Okay?
You are the boss, and there are 5 different. You have got 4 different employees. Okay, one is ultrasound machine, one is artificial intelligence, one is genetics, and one is post-surgical treatment. So you need to control all of them. It is you who need to control. It is never your employee who should control you. Am I right? Exactly what if you follow this line, you will be able to control your machine, AI, genetics, when, how, and where to do it. That's where is going to be the future.
Thank you very much. Please, Professor.
you're controlling them, who's controlling you?
Give a big applause, please, for our distinguished speakers for obstetrics and gynecology. So thank you very much, Professor Josh Gondos and Dr. Pasal Arya.